Okay. Since it's a couple minutes after, well, 2 o'clock in some folks' time and 1 o'clock in Texas, we'll go ahead and get started. My name is Whitney Vickery. I'm an internist based out of Blue Pearl in San Antonio. And I'm going to talk about two somewhat similar articles. Both about idiopathic functional urinary outflow obstruction, or also known as reflex dyssynergy. So just a little bit of review. Micturition is the kind of the passive storage of urine, and then the active voiding process. And with reflex dyssynergy, we're most concerned about the voiding phase, and this is primarily controlled by the parasympathetic nervous system, where there are impulses coming from the pontine micturition center that are relayed to the detrusor muscle via the pelvic nerve, stimulating contraction. And at the same time, there's inhibition of both the hypogastric nerve and the pudendal nerves that are allowing relaxation of the internal and external urethral sphincters to facilitate voiding. And so with disorders of voiding, we can kind of separate those into mechanical and functional categories. Mechanical being, of course, things like stone disease, masses, or proliferative urethritis. There can also be things such as strictures, blood clots, or foreign objects. And imaging in these cases is really key to identifying a lot of those disorders. Whereas the functional voiding disorders are kind of grouped into things with the neural system going wrong, and then things where there's not obvious neuro disease, and these are kind of now referred to as the idiopathic functional outflow obstruction, or what used to be called reflex dyssynergy, dyssynergy, or detrusor urethral dyssynergy. And so for the functional cases, the neural assessment is really important. Now, this disorder, reflex dyssynergy, I'm not sure I can kind of get myself to stop calling it that and move over to the longer version, but this is characterized by insufficient relaxation of the urethra at the same time as that detrusor contraction. Leading to functional urethral obstruction and retention of urine. And interestingly, in people, there's a somewhat similar condition that is referred to as detrusor urethral dyssynergy. But this is more specifically associated with certain types of central nervous system disease. And so this kind of human terminology and its association with CNS disease is part of why the terminology has shifted from reflex dyssynergy to this functional outflow obstruction. So definitive diagnosis of this condition does require urodynamic testing, but in our patients that can be really difficult and challenging, both from the standpoint that sedation and anesthesia can affect urethral and bladder pressures and compliance, but also the need for specialized equipment and staffing and training to use those devices. And so these are limited in their availability, and I don't know if anyone is working on having those in their practice. I'd love to hear about that at the end. I think these historically have been more in the academic referral type setting, and maybe not so much in a lot of private practices. So because we don't have easy access to urodynamic testing, this is often a diagnosis of exclusion, ruling out all causes of mechanical obstruction, as well as doing our best to eliminate neuro diseases as a cause of functional obstruction. And so the functional outflow obstruction, or reflex dyssynergy, is typically characterized by stranguria, or in some papers, they kind of have a broader category of dysuria, being painful or uncomfortable. urination. So sometimes the terminology is varying a bit between these two papers. But generally, they're going to see kind of normal initiation of urination with some stopping and starting or attenuation of the urine stream. Kind of historically or classically, we think of the spurting or dribbling or a thin urine stream, and then perhaps the dog having multiple attempts at voiding. And they may or may not have overflow incontinence depending on the degree of urine retention. And some of the older studies looking at this condition kind of reference this post-voiding residual volume of half mil per kg as being what's considered abnormal, whereas in the more recent consensus statement that ACVM has put out, they kind of have a little bit bigger range. So considering things less than 1 mil per kg as normal, greater than 3 mils per kg definitely abnormal, and then there being some gray zone in between there. And in that consensus statement, they also mention this formula for using ultrasound to kind of calculate bladder volume. So for this journal club, I wanted to look at these two more recent papers. One is out of JVIM in 2023, and that's the idiopathic functional urinary outflow tract obstruction in dogs. And this is a retrospective case series of 31 cases. And then the other being out of the Journal of Small Animal Practice. This study took place in the UK and was out of 3 different referral centers. Similar time periods, fairly long period of time. Both of these were over 11-12 year period. They were both retrospective, descriptive sort of case studies and similar numbers of dogs. The JVIM study was done all at UC Davis and had 31 cases, whereas the UK study had 35 cases. And in the JVIM study, they did kind of make a point of separating out dogs that had some presence of neurologic disease that they did not believe was related to the voiding disorder that they had. So in this case study, there are some included that did have some neurologic disease. And so we'll kind of go back and forth between the two. I felt like it was easiest kind of just to compare these two studies. They're a little bit different in some ways, but have some similarities. So nice to kind of look at both populations together. So for materials and methods, the JVIM study was primarily looking at dogs who had a final clinical diagnosis of functional outflow tract obstruction with stranguria and either a large bladder or overflow incontinence noted. So these dogs were in their record already having kind of the diagnosis of reflex dyssynergy. And for this group of dogs, their imaging studies to rule out mechanical obstruction were more narrow than in the UK study. And in this one, they utilized either, and then sometimes both, cystoscopy and a contrast cystourethrogram. They did exclude acute neurologic diseases that seemed to coincide with the voiding disorder. So those were not included, but there is a subset of dogs in this population that had some neurologic symptoms that they felt were unrelated to. Some of those may be predating the voiding disorder or things that may not have a close association with the voiding disorder. And they did in the study use kind of a scoring system to try to more objectively assess response rather than just kind of going on subjective approach in the as this was a retrospective population. So in the UK study, their kind of inclusion criteria were dogs who either had dysuria or stranguria. These were in kind of 2 of the referral centers. And then in the 3rd referral center, they were actually able to search final diagnoses of the Detrusor urethral dyssynergy. So a little bit differences in kind of inclusion parameters as far as diagnoses. They did also make a point of excluding any detectable obstructive disease. They had a little bit broader criteria for imaging, where they would allow abdominal ultrasound, CT, cystoscopy, or contrast study. And in this group, they did exclude any detectable neurodiseases that might affect micturition. They did assess outcome and response to therapy, but this was much more subjective and was assessed by the authors of the study, looking at kind of good, partial, and poor response based on their review of the cases. So in both studies, if there was bacteriuria or positive culture or clinical signs that could be attributed to bladder infection, they only included these dogs if the signs persisted following resolution of the bladder infection. They all kind of looked at a variety of signalments, presenting complaints, exam findings, diagnostic data, both biochemical and urinalysis data, as well as imaging findings. And then treatment was a big part of these studies, and then response to treatment and outcome of the dogs. And they primarily looked at descriptive statistics. So in the JVIM study done in California, they showed that Labradors and German Shepherds seem to be at increased risk. These were the most common breeds presenting in this study. They had a bigger population of males, as we kind of would expect, more neutered males and some intact males, and they did have a few females. The average age was 6.9 years, so a little bit older than some previous studies have seen. And these were primarily large breed dogs, although there was some variation with some smaller breeds included. And so they separated the dogs into non-neuro symptoms, essentially, and neuro signs. So there were larger population of dogs who did not have any appreciable neuro symptoms, and a few dogs, 8 in total, that did have some neural signs. All of the dogs in the study presented with stranguria, and about half also had some overflow incontinence. Compared to the UK study, they saw more Labradors and Golden Retrievers, as well as bigger proportion of crossbreeds. And they had a little bit closer split between intact males and neutered males, and this may be more the tendency of having dogs intact more in Europe than we do here. And they also saw a couple of female dogs in that study. Very similar age and body weight characteristics in their population. Still had some small dogs, or and then the female dogs, of course. And all these dogs presented with dysuria, which they kind of used more as an umbrella term, with about half having an altered stream of urine and about half having more specifically stranguria. And so in the JVIM study, I thought it was interesting. They did have a few dogs with bacterial growth in their urine that did remain clinical following treatment of their bladder infection. And there were also 8 dogs who were already on antibiotics at the time of their negative culture. And the other interesting thing biochemically, at least in this study, I thought there were a number of dogs that did have elevated CK. And that's not, I guess, not something I had thought of or seen before, at least anecdotally in my patients, but I suppose if there's lots of excessive straining, that might be reasonable. In the UK study, they did have a couple of dogs also having bacteriuria and persisting with clinical signs following treatment. An interesting thing in this study, the majority of dogs, they required 2 different imaging modalities to kind of feel good about ruling out mechanical obstruction with abdominal ultrasound and a retrograde cystourethrogram being the most commonly seen studies in that population. Now back to the JVIM study, their most common treatments used in these dogs included prazosin, tamsulosin, bethanical, and diazepam. All the neurologic dogs and the majority of the non-neuroscience dogs received alpha antagonists. And they did have a variety of other therapies that were used in this population of dogs, including phenoxybenzamine, methocarbamol, cisapride, NSAIDs, and glucocorticoids. And there were some dogs who were receiving intermittent catheterization or even a kind of long-term indwelling catheter. And in the UK study, they found an average of 2 drugs needed per dog. Most of the dogs were on some kind of smooth muscle relaxant, whether that was prazosin, phenoxybenzamine, or tamsulosin. And I think it's interesting that tamsulosin was used a little bit less commonly in that population. And I would love to know if that's something that's just newer to the UK, or kind of why the difference, as there were similar time periods in this study. And then the skeletal muscle relaxants were also used in about half the dogs. And in this population, they did include some dogs who had to have long-term catheterization. They did talk about dogs who were castrated, especially those who were castrated at the referral center. And then a few of these dogs had cystostomy tubes placed. Neither of these studies really looked at dogs who were requiring urethral stenting for treatment. So the JVIM study, they used an outcome scoring system between 0 and 3, with the lower score being better outcome. So 0 being dogs who could void normally, 1 being dogs who were still having some stranguria but didn't require any additional interventions, 2 being dogs with stranguria who needed bladder expression, and 3 dogs with stranguria who needed catheterization to address their symptoms. And so the median outcome score with all of the dogs was 1. And interestingly, 10 dogs were able to come off of all of their meds completely. However, 1 of those dogs was still getting kind of long-term intermittent catheterization despite being off of all of his medications. Some of the neuro dogs did have improvement in their neurofunction, but had static or improved outcome scores. And then a few dogs also had worsening of their function, but had a 0 outcome score or improvement in their urinary signs. And so the point they were kind of trying to make with this is that these neuro disorders and the voiding disorder may not always be going hand in hand here. And so they did see unfortunately a smaller population of dogs having more reevaluation. So the longer term response to therapy was only able to be evaluated in about half of the dogs in this study. So there were only 15 dogs that had 2 or more reevaluations. 3 of those dogs were neuro dogs. All of them were either non-responders or had relapses, whereas 12 of the non-neuro symptom dogs, there were only 5 non-responders or relapsers and 7 dogs who responded appropriately to treatment. They did kind of talk about castration a bit. So 5 of the 6 dogs who were castrated had improved outcomes, some of those coming off meds completely. And then they also noted that 10% of dogs, which, in a population of 30 is 3, were euthanized because of persistent clinical signs. All of those dogs had an outcome score of 3, meaning they were straining and needing catheterization. So results-wise in the JSAP study, these authors had more of a subjective assessment of response, either good, partial, or poor. The majority of dogs were having good response, and similar numbers, about 20%, having either partial or poor response to treatment. And their overall population, all but one dog was discharged from the hospital, and that dog died acutely a few days after starting phenoxybenzamine and bethanechol, and the cause of death in that case was not known. Their overall, they did look at, for the dogs who they knew responded to treatment, or we had time to response to treatment. That was not all dogs in the study. The average time for improvement was about 11 days, which is kind of similar to the better responders in the JVIM study as well. So they had 20 dogs who had good response. Most of those responded to medical treatment alone. A few of them required both medical treatment and surgery, and this is surgery at the referral center, not all the dogs who were castrated in the entire study. But there were 2 dogs who were castrated alone, and then 2 dogs who were castrated and had cystostomy tubes placed. They had a majority of these good responders were on the smooth muscle relaxers. About half the dogs also had skeletal muscle relaxers, and then about a third each of bethanechol and NSAIDs. The majority of the intact dogs in this group were castrated. So for partial responders and poor responders, interestingly, the breakdown of medical therapy was fairly similar between all 3 of these groups. The dogs who were castrated was a little bit different. The partial responders, these dogs were all on medical therapy, so none of them had any surgical interventions, at least in the referral hospital, and only one of the 2 intact dogs were castrated. And then in the poor responders, none of those dogs received NSAID use, was the biggest thing with medications. And then they did have several intact dogs who were not castrated, and they had several dogs who were receiving sort of longer term catheterization of some sort. They did mention that several dogs required dosing changes or stopping of drugs for medical management due to side effects, and these were primarily sort of sedation and lethargy in the smooth muscle relaxer or skeletal muscle relaxer groups, and then GI upset with the parasympathomimetic drugs. They did have 5 dogs euthanized during the follow-up period of the study, and 3 were related to their voiding disorder. So in the JVIM study, some of their kind of points were that this is a fairly uncommon disease with, only a few, per year over, fairly long study period. But it is a condition, at least the ones who make it to referral center, that seems to have fairly considerable morbidity and even mortality. One of the takeaways was that, it would be great to have a better way to objectively assess response to treatment, similar to having a scoring system for incontinence, like Dr. Sleed was talking about last week, of, having, a scoring system for ease of voiding or lack of stranguria would be helpful in these cases, to have a more objective way to assess response. This does seem to be a disease of young, middle-aged, large breed male dogs, although it does occur in females and small breeds. And in the States, at least, labs and German Shepherds may be at increased risk, which, anecdotally is, fits with the cases that I've seen. Another takeaway is that the urinary status in neurologic patients can be dynamic, and recovery of neural symptoms and urinary function may not go together. You might have one without the other, and so it is not always a good way to predict whether they're going to respond to treatment or recover fully. Um, and then for these guys, it seems like bacteriuria is perhaps a secondary effect of urine retention and not always a cause of stranguria, as there were a number of dogs who, still continue to have symptoms despite having clearance of their bacteriuria. And then they did see about almost 40% of dogs having complete resolution of symptoms, but noted that there were variable times to kind of reach this goal. Whereas in the JSAP study, this also found young, middle-aged, large breed male dogs with golden retrievers and crossbreeds seeming to be a little bit more common in the UK study. They really, I think, would have been helpful to have more consistency in describing urologic symptoms. So that's sometimes the nature of the retrospective study. All the dogs here presented with dysuria, or in the DACVIM study, they were more specific about stranguria. The vast majority of the dogs receive smooth muscle relaxers, about half skeletal muscle relaxers, and then about a third each receiving those parasympathomimetics or NSAIDs. Did note that it's really important, of course, to address outflow obstruction before use of botanical, which is something I struggle at least a bit with, that being a quick go-to drug, at least, when I'm seeing transfers from ER, things like that. I think everyone's much more uh, familiar with botanical, but not necessarily with the need to relieve functional outflow obstruction. So that's always something I'm talking about with ER doctors and interns. And then none of the dogs who had poor response received an NSAID, which was interesting. And, that may just be selection based of the dogs who were already worse off to begin with, rather than, that might have been the thing that helped them. There were 7 intact male dogs who did have resolution of all their symptoms when castrated, and 3 dogs who had no response to treatment and were not castrated in this study. The majority of dogs had either good or partial response to therapy, and this is consistent with historic studies who have kind of noted a 60 to 100% response rate. There were about in the dogs who discontinued medication, about half of those were good response dogs. But they did have a few relapses. So they kind of highlighted that, long-term medical management is probably to be expected. And then they kind of broke it down between the good responders and the partial responders as far as length of time to achieve resolution. And the good responders tended to have a shorter time to resolution of symptoms than the partial responders, which makes sense. I think really they needed more objective ways to measure treatment response in this study. So the limitations, of course, the retrospective nature, it makes variations in use of terminology and medical record keeping of, getting some of those really important details in these cases that really are a lot about kind of history and presenting complaints. The subjective nature of assessing response to treatment is, of course, a challenge in a retrospective study, and the fact that the therapies, although fairly similar across studies, were not standardized. I think the small populations and this being a relatively uncommon disease also is a struggle. And are these cases that are being seen at referral centers the more severe ones that are the ones that make it there? Is there maybe a population of dogs with more mild form of reflex dyssynergia that just aren't making it into these studies? And then there was fairly infrequent measuring of post-voiding residual volume, either with volume measurement from a catheter or with ultrasound. I think the inclusion of dogs, since we are very careful about defining this as a idiopathic disease where there's not neurodisease, and that it's a diagnosis of exclusion, I think the inclusion of some dogs with neurodisease makes this, a little bit challenging. And then the low numbers of dogs who are having, multiple follow-ups to assess outcome. And so, thoughts moving forward, and if anyone has anything to add, I'd love to hear it. This is a disease. It'd be great to have a prospective study where there was a more standardized approach to therapy, better documenting of residual volume, using standardized terminology, and maybe a more objective outcome response. But I think this would be really challenging in one institution alone with tendency towards small case numbers. And also, capturing perhaps more mild forms of disease that aren't going to make it to these bigger referral centers. And then I think the fact that this is a large breed dog problem as a whole, I think the impact of subclinical neurodisease is really interesting. Having worked in the military with a large population of German Shepherds and working dogs, where lumbosacral disease is such a challenge, I wonder, what is the impact of, we just haven't diagnosed their lumbosacral disease yet with reflex dyssynergia. And then I think, is there a place for medication trials? And some of my clients come and they don't have the funds to do workup that involves cystoscopy or contrast study and things like that. And so for these more mild cases, is there a place for doing a kind of medication management trial similarly to how we sometimes do in dogs with USMI? And then I think the JSAP study was really interesting, especially about the thought of, when to reach for NSAIDs, or is that something we can use as adjunctive management? So that is all I have for you guys. If anyone has thoughts or questions or anecdotes, I would love to hear them.
Well, thank you so much, Whitney. That was very informative. A lot of data there.
Thanks, Dr. Cowgill.
Anybody else have questions or comments? Other ideas? Trials start?
This is Rachel, the pathologist. I guess, and I'm not a diagnostician as far as seeing these patients, obviously, in clinic, but I have had a couple of times where people have biopsied urinary bladder, and that was their working diagnosis. And I guess I'm not sure what I'm supposed to be doing in that scenario other than saying the urinary bladder muscle looks normal. I'm not sure why. I mean, it's not from tertiary care. It's almost like from primary care physicians that are thinking a biopsy might be worthwhile, and I don't think it is. Is there anything like I can point to say these dogs should not be biopsied?
Are they biopsying them as to try to diagnose reflex dyssynergia? I guess I'm
Yeah, I'm confused as to why they biopsy it as well. Like, we'll get urinary bladder biopsies. I'm wondering if they think that the smooth muscle might look abnormal histologically, or I guess maybe just to rule out that there might be some other underlying cause, but obviously a small sample, a bladder, is not going to help me if there's not a visible mass. But I guess because I've reached out to JD before too to be like, I don't even know what I'm supposed to say in these scenarios.
Yeah.
But I guess I can just say that it's probably not the best way to work up that patient, and that imaging is more appropriate for this scenario.
Yeah, I mean, I guess on the one hand, I'm impressed. Like, I run across more primary care vets that, like, this is nowhere on their radar, so that they're thinking about it, I think is great. I mean, I may biopsy a bladder cystoscopically sometimes if if the wall looks abnormal, an effort to maybe find infection that I'm not catching on urine culture. So I don't know if if that is some thought behind it, but yeah, I guess for me, that wouldn't be something I would normally jump to in these guys.
Well, at least I can cite these two papers to say that for suspected diagnoses, these are the best, or the most recent discussions about workup and management of these cases. So at least I can have that in my pocket for my discussion comment. It's only happened twice, but each time I've been like, I'm not sure why I reached over a biopsy in this scenario.
I think, I mean, at least they're thinking of that as a differential, and the ACVIM consensus statement also has some really helpful information in there as far as workup and rollouts for both mechanical and functional urethral obstruction. So that, you know, for a primary vet, that might also be a helpful resource to cite too.
Yeah, this is Allie Kendall, Rachel. We did try to I've had phone calls about that as well from primary vets, and we did in the consensus statement. That's why we really put a lot of flow charts and different charts on how to work them up. Because towards the end, the consensus statement, I feel like we started leaning more towards gearing towards general practitioners, because it just seemed like, especially for voiding disorders, there was a big lapse of knowledge and diagnosis. So there is a nice flow chart that we put in that consensus statement on how to work up a voiding disorder that you can send them.
Thanks. Cool. Thanks.
Anything else for Whitney? Well, thank you very much. It's always a big job doing one of these journal clubs, and so we certainly appreciate your contribution.
Thank you so much, Whitney.
Thank you, everyone. Have a great weekend.
Great job, Whitney.